here and have the opportunity to speak to you as one of the MDS past presidents in this series of MDS Presidential Perspective lectures. My presidency was in 2000 and 2001, so it's 20 years ago, and it's been a truly rewarding time. And as you see from the title of the lecture that I've chosen, I'm going to be in this historical mode a little bit, but coming from the past, trying to also look a little bit into where the future might lie in terms of treatment of Parkinson's. Before starting this off, let me just show you my conflicts of interest. I will be mentioning drugs mainly as treatments for Parkinson's disease, and I've been involved with a number of companies in their development programs for PD therapies, and you can see them listed here. What I was thinking of covering today about the past was really a short glimpse into how it all started with James Parkinson and his thoughts about treatment of the disease we name after him. And of course, I will be speaking a little bit about the fascinating history of levodopa as a treatment for Parkinson's disease. And then I'll be speaking about how this old drug, levodopa, is still very much alive, and how the topic of drug delivery is one of the major topics in current PD treatment routine, but also research and ongoing development. And in order to not only speak about drugs, I will, of course, mention the other revolutionary treatment, that is a surgical one for Parkinson's disease, before moving into some thoughts about where we might be going regarding treating this disease, mainly treating it pharmacologically. That's the outline and the remit of what I'm intending to speak about. So the beginnings. This is a quote I'm showing you from James Parkinson's monograph that he, as you know, published in 1817. And the concluding chapter 5 of this monograph has some deliberations in it by James Parkinson on how this condition might be treated, and you can read them for yourself. And truly what James Parkinson is considering here is in the spirit of many of the 19th century and even earlier treatments in medicine, where invasive measures were taken to purify the body from illness-causing juices or blocks. And he indeed felt there might be relief to be obtained from placing incisions in the neck and putting certain substances in those incisions to induce a purulent discharge, and thereby relieving congestion of fluids, veins in the medulla. This came from his observation in one of his patients that had come to autopsy, where there was indeed a finding of enlarged veins in the posterior fossa. So this is what James Parkinson wrote. We smile about this today, but in the same chapter, he also makes this comment that he believes that until we have more information about the nature of this disease, the employment of internal medicines, let me say the employment of drugs, is scarcely warrantable. And this is something that is very modern and very true today. Before we embark upon treatments, for them to be successful, we must understand the pathways we're targeting, the mechanisms of disease underlying, and the role that these pathways may play in the molecular pathogenesis. This is how we would currently and are currently thinking. So James Parkinson was right there with his thinking. Now, there weren't any medicines available at the time, and it took a little while, but it was still in the 19th century that this famous man and his team at the Salpêtrière Department of Neurology in Paris, Jean-Martin Charcot, when he and his school started to experiment with extracts from this plant you see on the slide, Hyoscyamus niger, a belladonna alkaloid plant, and extracts from here contained belladonna alkaloids, anticholinergics. Of course, it wasn't known that these alkaloids had anticholinergic activity, but they were then used with success by Charcot and Ordenstein in particular in his department to relieve some of the symptoms of Parkinson's disease, in particular stiffness, rigidity, and also the trembling. And here I've taken this from Christopher Goetz, another past president of our society, who wrote a wonderful book with others on Jean-Martin Charcot. And here's a prescription of hyoscyamin, of extracts from this plant for a patient with Parkinson's disease, dated the 4th of May, 1877, in the handwriting of Charcot, where he prescribes a certain number of granules to be taken on certain times and certain frequency per day. This was, if you wish, the beginnings of drug therapy of Parkinson's disease. But the efficacy was limited, naturally, although, as you all know as well, these observations on the efficacy of belladonna alkaloids eventually led to the development of synthetic anticholinergics, which were the drugs of choice and the only available drugs to treat the symptoms, the motor symptoms of Parkinson's disease, well into the 20th century. But the big breakthrough came in the 1960s with the discovery of levodopa. And the slide here illustrates three eminent researchers that made major contributions to this development of introducing levodopa, discovering levodopa as a treatment for Parkinson's disease. Right here you can see Arvid Carlsson, the Nobel Prize winner. He was awarded for his work in the field with the Nobel Prize for Physiology or Medicine in 2000. And his discovery had been that when he depleted animals, rabbits, from their brain dopamine by giving them reserpine, these animals became profoundly akinetic, and that he could restore mobility in these rabbits by injecting them the dopamine precursor, the amino acid levodopa. And this man, Olo Hornikiewicz, a pharmacologist from Vienna in Austria, he set out to investigate brain slices, the brains of people who had died with Parkinson's disease, and was the first to show with his co-worker Ehringer that there was a marked depletion of brain dopamine in Parkinson's disease. And he even, teaming up with a neurologist, Birkmeyer in Vienna, injected levodopa, as Carlsson had done with his rabbits, into patients and saw remarkable effects on mobility and other Parkinsonian motor symptoms. They reported this in German in 1961, but this didn't surprisingly lead to the breakthrough of levodopa as a PD drug. This only happened after George Kotzias, number 3 on this slide. George Kotzias then gave large oral doses of levodopa to chronically ill Parkinson's disease patients and observed miraculous effects and published them in the New England Journal of Medicine in English. And that caught the attention of the world and was the beginning of levodopa therapy. So these were the pioneers. As an anecdote, I'd like to mention in passing at this point, Carlsson, the Nobel laureate, was awarded the prize for his experiments in rabbits and his injections of levodopa in rabbits, you might say. And long before him, another pharmacologist, Carlsson is a pharmacologist, another pharmacologist from Austria at the time, won the Nobel Prize in 1936. And he defined a drug as a substance which, if injected into a rabbit, produces a paper. I don't think he would have dared to say a drug is a substance which injected into a rabbit produces the Nobel Prize. But anyway, I just like this little anecdote as I speak of Carlsson's contribution. And here we are. This was 1950s. That is, Carlsson experiments went on, and it was the 1960s that Hornikiewicz and Carlsson did that work. And to this very day, despite all developments that took place, levodopa still is the most efficacious drug, as you all know, to treat the motor symptoms of Parkinson's disease. Nothing has been developed since that would surpass the efficacy of levodopa. And luckily, levodopa is a very well-tolerated drug as well, and all patients with Parkinson's eventually require it. There are some shortcomings. Unfortunately, levodopa could be regarded as the solution of symptomatic motor treatment, at least of Parkinson's, if there weren't these issues around its chronic use that leads into the development of motor complications, response fluctuations, and neuroinduced dyskinesis of different frequencies in different series, depending on age of patients, depending on the type of series, randomized controlled trial, or a wild type observational study in routine clinical patients. Rates vary, but by and large, more than half of the patients treated chronically with levodopa for more than 5 years will develop these problems. And levodopa dose is a risk factor. The higher the dose, the more likely patients are to develop these issues. Younger age is a predisposing and risk factor, and disease duration, not so much treatment duration, it's rather the disease duration that contributes to risk for the development of these. And again, since I promised to speak about the past and before moving to the present and to the future, this problem with levodopa was recognized from the very beginning. It's not a recent discovery after many years of levodopa usage that there can be these problems. George Kotzias himself remarked on these phenomena. I'll show you a brief video clip where he comments on
that. The third problem is that we encounter certain intermittencies of the action of the drug, where a person is doing quite well, and all of a sudden for an hour or for half an hour, he loses suddenly the effectiveness of the drug. This, again, could not have been predicted.
So from the very early levodopa days on, investigators and clinical researchers were aware of motor fluctuations, and we're still struggling with them. We have seen major advances in terms of trying to modify the pharmacokinetics of levodopa to alleviate motor fluctuations. We've come to recognize that it is the short half-life of levodopa, together with erratic absorption from the gastrointestinal tract, delayed gastric emptying, food interactions, particularly with amino acids, that all contribute to the discontinuous delivery of levodopa and dopamine derived from it to its target in the brain. And there have been remarkably successful attempts to modify this, including the development of COMT inhibitors that act peripherally and increase the half-life of levodopa and the bioavailability, centrally active inhibitors of MAO-B that contribute to longer persistence of dopamine in the synapse after release, blocking the enzymatic breakdown by MAO-B, which is located in glial cells, and also synthetic dopamine agonists have been developed that have longer half-life, most of them, than levodopa, and thereby also prolong the action and reduce motor fluctuations. Unfortunately, none of these drugs has been shown to prevent the development of levodopa motor fluctuations or dyskinesias. Attempts to show that COMT inhibition, for example, might not only be a useful treatment for motor fluctuations, but might even delay or prevent the development of fluctuations and dyskinesias failed. So we're lacking treatment for this. And this is why there is ongoing research to improve the delivery of levodopa. And this is something that is going on presently. There are continuing efforts to develop novel extended release formulations of levodopa to provide this more continuous delivery, even with oral routes, via oral routes. And I'll briefly mention just one. You see on the slide graphically depict the accordion pill, which is a gastric retention formula that has had very promising pharmacokinetic results in terms of longevity of plasma levels over many, many hours. But a recent pivotal trial just narrowly missed the primary endpoint of off-time reduction in comparison to immediate release levodopa. The book is unclosed on it. There's another extended oral release formulation that's on the market in the US and in other countries, unfortunately not in Europe. And that particular preparation, which is marketed as Rytary in the US and is depicted here in this particular study by Stacy and colleagues, where the clinical pharmacokinetics of standard immediate release levodopa, the marketed extended release formulation in blue, and a novel, modified, improved controlled release formulation called IPX203 were compared, and you see that the orange curve here produces more persistent reductions following a dose in the MDS, UPDRS scores, and also in terms of response criteria of patients is superior to the marketed available extended release formulation, and of course much superior to immediate release. And a phase 3 trial of this novel formulation is presently recruiting in the US. And I'm only showing this as an example that even after so many decades of use of levodopa, we're still researching this drug and we're still working on its pharmacology to enhance delivery and continuity of clinical effect. And if any of these programs should be successful, it will be a further major step forward for our patients in their routine treatment. Another area of recent and ongoing developments is in drug delivery is related again to levodopa, with an attempt to provide on-demand, fast-acting levodopa to the system to interrupt intervening off periods in a reliable and fast fashion. And the principle used here is an inhalation preparation where capsules of levodopa, particular preparation of a levodopa powder, are put into an inhaler, and patients can, taking deep breaths with this inhaler instrument, induce very rapid rises in their plasma levels through alveolar, through pulmonary absorption. And there's recently been a phase 3 trial showing the efficacy of this on-demand delivery of levodopa through the lungs in a study that had 3 arms with 2 different doses of levodopa and placebo. And the primary endpoint of the study, which went on for 12 weeks, was the levodopa induced or drug induced or treatment induced reduction in UPDS scores 30 minutes after inhalation. You see the placebo curve here and the two doses, and the primary endpoint was the 30-minute result, and that was hugely positive in the trial. There are improvements apparent already after 10 minutes in the UPDS scores and after 20 minutes, but this was set as the primary outcome. And numbers of patients or percentages that had maintained a full-on state or reached it by 60 minutes post-dose at week 12, which was a secondary outcome, is depicted here. You might wonder, why wouldn't this approach not turn everybody into a full-on response? And that's probably due to the fact that there are limits to the amount of levodopa that can be delivered with the system. Currently, in this particular trial, the higher dose was 84 milligrams, corresponding to a conventional oral dose of 100, and that may simply not be enough for all patients to induce a full-on. Speaking about on-demand therapies that have recently been developed, one relates to apomorphine. In Europe, at least, and in many other parts of the world, including the US, subcutaneous injections of apomorphine have been used. The uptake has been particularly large of this treatment in Europe, and that's something that has been in clinical routine since the late 1980s already. The problem has always been with subcutaneous apomorphine injections that they do require subcutaneous injection, a certain handling skill using these pen injectors, problems occasionally with skin tolerability, nodules, reddenings, in rare instances even infection or abscesses, so that there are limits to this subcutaneous mode of administration that have probably contributed to this treatment not being so established, broadly established as it should be from the efficacy perspective, apomorphine being the only agonist drug that has the same effect size on motor symptoms as levodopa does. So this sublingual film development was of particular interest because it bypasses, of course, the need for injections. It's a sublingual strip, different sizes provide different doses, and in this phase 3 study, doses were titrated up to 35 milligrams of the sublingual apomorphine versus placebo 12 weeks, and a very similar endpoint as with the levodopa inhaler study, the reduction in UPDS scores at week 12, 30 minutes after dosing. And you see how this is, again, a very marked effect size between the placebo effect and the apomorphine sublingual effect at week 3. And that, again, as was the case for the levodopa inhaler, led to the regulatory approval in the United States recently, also for this sublingual apomorphine preparation. At the other end of the spectrum of improving delivery, of course, of levodopa is the attempt to try and really give the drug continuously under the assumption that physiological dopamine action and activity in the brain require continuity of release and relatively constant availability. And we're using in clinical routine intestinal infusions of levodopa. We're using subcutaneous apomorphine infusions. And of course, this intestinal infusion system has some invasiveness to it, so that subcutaneous levodopa delivery would be an advance in this regard and is being actively researched. 2 programs are ongoing, at least. One is the Neuroderm Mitsubishi program of this soluble levodopa product administered together with carbidopa, producing very, very, very nice and stable levodopa plasma levels, and phase 2 data suggest efficacy also on off time, and a large international phase 3 double-blind, double-dummy trial has been initiated and recruited about 100 patients so far. And another now phase 2 program is underway for a levodopa prodrug subcutaneous formulation by AbbVie. This is from a poster that was up at the AAN in 2019, showing again the nice constant levels of levodopa with this subcutaneous infusion of this product versus oral treatment. So we're seeing yet another stage of levodopa development where we might be able, if these programs are successful, to offer subcutaneous continuous levodopa infusions. And if pump technology moves forward and pharmacology technology moves forward, these may even end up as small patch pumps of the type in use in diabetes, which do have very low weight indeed and might lead to a new form of levodopa delivery even in earlier phases of the disease. That's entirely possible, depending on the outcomes of the currently ongoing trials. And speaking about currently ongoing trials of improving levodopa, there is another end of invasiveness here, and that is intracerebral drug delivery via gene therapy. Already for more than 10 years, there have been phase 1 studies showing the feasibility and also some efficacy signal of gene therapies with vector-delivered amino acid decarboxylase gene therapy delivery into the striatum. And the most recent activity in this regard is related to an adenoviral vector delivered ADC gene with MR guidance to achieve as best as possible coverage of the posterior putamen with 2 delivery sites. There have been encouraging data in small numbers of patients, open label data, published in the Movement Disorder Journal this year by Jay Nutt and colleagues. And at the MDS Congress in September, this delivery mode of the ADC gene was reported in this smallish group of 15 patients for extended follow-up over 3 years, with indeed remarkable reductions over 3 years in oral therapy and improvements in terms of reduced off and enhanced on time. So it will be very exciting to see how this program will move forward, as is true for this one, of a three enzyme viral vector delivery, a tricistronic vector delivering these 3 enzymes that are critical for dopamine synthesis, the GTP cyclohydrolase 1, tyrosine hydroxylase, and ADC. And following these phase 1 safety results, program is actively recruiting right now to see whether this can be a way of improving function in these patients. But as you all know, we don't know about the outcome of gene therapy, which is associated with stereotactic brain surgery. But the true revolution of surgery in Parkinson's was, of course, the introduction of DBS. I do not have time to follow that exciting path backward in how stereotoxy developed and how it once was lesional stereotoxy was a treatment of choice, particularly for tremor in the first and middle part of the 20th century. But I want to cut the story short with mentioning the seminal discoveries by Malon DeLong, Alexander and his colleagues about the organization of the basal ganglia motor circuitry and the scheme and hypothesis of different parallel pathways and the motor pathway with indirect and direct projections from the striatum via the globus pallidus back to the thalamus and motor cortex. Based on these concepts, Aziz and co-workers in the Movement Disorder Journal almost 20 years ago reported that lesioning of the subthalamic nucleus was able to markedly reduce Parkinsonism in the MPTP primate model. And this was subsequently shown also for another type of intervention that had become possible by the time high-frequency stimulation of the subthalamic nucleus had the same effect. And then there were these 2 courageous Frenchmen, the neurologist Pierre Poulac and the neurosurgeon Aline Louise Benabit, who in 1993 implanted their first Parkinson's disease patient with electrodes into the subthalamic nucleus bilaterally, and indeed reported on remarkable effects of this procedure, originally in the Movement Disorder Journal, later in the Lancet. And I will show you from the Movement Disorder Journal 1995 paper the video with the then editor of the journal, Stanley Fahn, our founding father of MDS, commenting on this short video clip. Just as you're very used to this now in the modern age of DBS to see these effects, but if you think back into the early 1990s, this was truly revolutionary and almost unthinkable.
He is able to stand up and walk, but with great difficulty. Both stimulators are successively switched on.
Parfait. Où? Ouais, décroiser les bras. Marcher vers la porte.
This was to all Parkinsonologists and all clinicians at the time. This was like a miracle experience. And the story has evolved dramatically. There's still the numbers of patients with Parkinson's disease that do require or receive DBS procedures is still low. It's less than 5% probably, but this field is rapidly developing with improvements in spatial specificity of the current and the voltage delivered to the brain using novel electrodes that allow for directionality of stimulation and placement of the volumes of tissue activated, that allow for current steering. There are exciting reports about adaptive closed loop stimulation where the electrode would sense signals like beta oscillations that are associated with off periods to induce stimulation. So this would no longer be a continuous effect, but an on-demand effect depending on these closed-loop signals. There are new patterns that have been investigated and are exciting. And I think we're moving to an area with these advanced electrodes and many stimulation patterns, mixing low and high frequency, that will increasingly require artificial intelligence in programming. And this is an actively evolving field as well. And imaging is exciting in the way that it allows for visualization, not only of electrode positions, but the relation between electric fields induced by stimulation and fiber tracts, thereby giving us ways to improve on side effects and understanding the underlying mechanisms, brain mechanisms we're influencing for certain treatment effects. Nonetheless, even though we have at least two truly revolutionary treatment developments in the history of Parkinson's disease, the introduction of levodopa, a drug, and the development of deep brain stimulation, a surgical and technical procedure. Unfortunately, these treatments, as you again all are painfully aware of, do not seem to change the progression of Parkinson's disease. Clinically speaking, they do change the course of Parkinson's disease. They prolong periods of life substantially where patients are fully functional, where patients have maintained quality of life and can go about their daily activities and hobbies. They have, as we've discussed, side effects as levodopa does with the development of fluctuations, dyskinesis, but again, we have measures to treat those, and particularly dyskinesis, for example, are wonderfully responsive to deep brain stimulation. But what really concerns us today in treating Parkinson's disease is that we see more and more patients, due to our successes with treatment, going into these late stages of PD with long duration of disease and evolution of poorly treatment responsive motor phenomena like postural instability, falling, actual deformities developing, dysphagia, dysarthria, and an increasing burden also of the non-motor side of Parkinson's disease with urinary incontinence, orthostatic hypotension, syncope, even cognitive decline, dementia, hallucinosis. All these problems are a big challenge to what we can do to treat them, and none of the treatments we have currently are really able to prevent the development of this, while they do wonderfully well in improving quality of life in these earlier stages. So we have the same need as we always had over the past decades to try and find something that would modify the progression of Parkinson's disease. And taking a quick look at the history, so to speak, of disease modification, when it started with the DataTop trial, which tested the antioxidant tocopherol, deprenyl, in a 2x2 factorial design, and was the prototypic large-scale, well-designed, controlled trial of disease modification. This was then called neuroprotection. And although the targets, be it antioxidant activity, be it mitochondrial function that was targeted with drugs, even inflammation, neuroinflammation with minocycline trial, or various agents that had shown in the laboratory that they could exert anti-apoptotic activity. As you know, all these many trials with thousands of patients and tens and hundreds of millions of dollars invested were either outright negative or at least inconclusive. So we have largely failed on this, and there has been debate why that was. Were these targets the wrong targets? Were these drugs the wrong drugs? Were the doses wrong? Was the design incorrect or not well suited? Were the outcomes insufficient? Were the patients too early or too late or not right? We don't know what the mechanism of failure was, but why I believe there is hope currently, again, after a dull period when disappointment about disease modification trials prevailed and companies withdrew increasingly, we're now in an era with a new explosion of interesting targets for disease modification, and that is largely due to the exciting discoveries around the molecular architecture and the genetic architecture of Parkinson's disease. I've listed here, I don't think 100% completely, but as an overview, a list of targets where trial activity has been placed on, and they include calcium homeostasis, iron. There's good evidence that there is maybe toxic influences of calcium, dysregulated calcium influx as a player in the pathology, the cellular pathology of Parkinson's disease. Increased iron content with effects on oxidative metabolism and on synuclein aggregation are in the focus. There has been recent interest in GLP-1 agonist and insulin signaling as a target. Neuroinflammation remains on the map. And of course, very, very prominently in recent years, synuclein proteostasis has moved into the focus, not least, mainly because synuclein is a major constituent, not the only constituent, mark you, but a major constituent in Lewy bodies. Not all, as we know now, not all types of Parkinsonism have Lewy pathology, notably LRRK2. Genetic Parkinson's may or may not have that pathology, but still, since discovering that mutations in the alpha-synuclein gene and also triplications or duplications in the normal gene, those of the normal gene, that they are sufficient to cause Parkinson's disease, and experimental evidence about prion-like behavior of aggregated polymeric forms, fibrillar forms of synuclein being transmitted from cell to cell. This has spurred a huge activity to target synuclein with different measures for disease modification trials, and clearance of misfolded synuclein and pathological species through the endolysosomal system has also moved into the target, and that's partly due to a genotypic risk factor, and that is GBA mutations that increase PD risk by dysfunctional GCase, a key lysosomal enzyme, links up the two fields of endolysosomal dysfunction and synuclein proteostasis. The ways that this complex is currently targeted explores all kinds of avenues, reducing production of synuclein itself with, for example, antisense oligonucleotides. This has not moved into clinical work in Parkinson's yet, but there is a currently ongoing trial of a synuclein antisense oligonucleotide in multiple system atrophy and atypical Parkinsonian syndrome. And of course, you are all well aware of these attempts to reduce huntingtin in Huntington's disease with this approach. And that's something that gains its rationale from the fact that overexpressing alpha-synuclein, increasing the amount of synuclein, can induce aggregation, misfolding, and pathology. And here is the hope that reducing the production to some extent might have beneficial effects on disease progression. And I mentioned endolysosomal clearance. And this is something that moved into the focus, as said, through the recognition that GBA gene mutations are an important, probably the most important so far, genetic risk factor, single risk factor for Parkinson's disease, and that in Parkinsonian brain there is a reduction of glucocerebrosidase activity, even in subjects that do not carry these mutations, and that decreased activity of GCase can enhance synuclein aggregation and oligomerization, and increase of GCase activity can have the opposite effect. So this has all spurred attempts to influence that pathway by different methods. I'll just show you one example that was recently published, where Tony Shapiro and his group in England repurposed an old cough drug, a mucolytic agent Ambroxol, giving it in very huge doses in a proof of principle and safety pilot study to a small number of patients with Parkinson's and GBA mutations, or Parkinson's without GBA mutations. And the exciting thing here, finding about the study, I find, is that it was possible, even though it was a very small group of patients, to show biological effects of Ambroxol, which crossed the blood-brain barrier. First of all, they were able to show this. They used very high doses of Ambroxol, but it did influence GCase protein levels that went up. It influenced synuclein levels in the CSF that went up. It led to decreases in CSF GCase activity, which was expected. As tissue activity would go up, CSF activity would go down. So there are signals that form the basis of currently ongoing new trials with Ambroxol, and then a large trial that uses a different approach to influence this pathway is via an enzyme inhibitor of glucosylceramide synthase. It's a substrate reduction approach to reduce the substrate of glucocerebrosidase, and the MOVES-PD trial that is ongoing, or almost has finished its recruitment, is ongoing, tests this hypothesis in 260 patients that this approach in GBA positive PD might exert positive effects on progression. The 4-week dose-finding part of the study in a small number of patients again showed that this approach has biological dose-dependent effects, where the drug, which I said is an inhibitor of glucosylceramide synthase, and thereby reduces the GCase substrate with this, which is glycosylceramide, and GCase splits that into glucose and ceramide, that you have a reduction of this GL1 level here shown for the CSF in a dose-dependent fashion. So there's biological activity in the pathway. Will it do good for patients? We will have to see from the outcome of the trial. There are earlier development phases for small molecules that are able to prevent the propensity of synuclein to aggregate and form fibrils. What I want to just at the end, going through this list of approaches, highlight is immunotherapy directed against pathological aggregated misfolded polymeric synuclein, both with monoclonal antibodies and passive immunization strategies, trials, and potentially also with vaccine. We're living in this age now where everybody's waiting for a particular vaccine to arrive. Maybe there will be a vaccine for Parkinson's one time. The idea behind this, as you probably all know, is that synuclein might, once formed in aggregates in cells, be exocytosed from cells, and that these pathological species of synuclein would, in a prion-like fashion, be taken up by neighboring cells, inducing similar pathology, and that would be a major mechanism in the progression of the disease, and that antibodies, either passively given or actively raised, would reduce this mechanism and thereby the progression of disease, the buildup of more and more synuclein load. That's the idea behind it. And as you can see, many companies have taken this up in development programs in different phases of development, and two of them, the Biogen program and the Roche program with Simpanimab for Biogen and prasinezumab, have progressed to phase 2. And at the MDS Congress in September, the week 52 results of this prasinezumab Roche trial with this monoclonal antibody were presented. This was from the part of the trial, first year, where placebo was compared to 2 doses given 4 weekly intravenously. The trial is ongoing, is its second phase for all patients of active drug. But the big disappointment, first of all, was that the primary endpoint, which was the total MDS-UPDRS scores, wasn't met. There wasn't a difference between placebo, the low and high dose, or the pooled 2 doses. But one of the key secondaries, the MDS motor UPDRS part 3 score, did show an effect or a difference, let's put it this way, between placebo and the different doses and the pooled doses. And this was true for the on-site rating and also the central blinded rating, on-site blinded and central blinded rating. So this study is going on, and it provides mixed signals for those who are skeptics, negative signals for those who are optimists, positive signals. If these programs should be successful, then immunization would be a very attractive approach. If antibodies could be shown to have disease-modifying efficacy, immunization would be wonderful, because it wouldn't require infusions every 4 weeks. It would require maybe once or twice a year injections. We performed a study together with Afiris and colleagues around Dr. Volz in Vienna on a vaccine based on this technology, where protein libraries are screened for suitable epitopes, in this case, immunogenic epitopes of synuclein of short amino acid lengths, between 6 or 7 amino acids, exchanging 1 or 2 of them to break immune tolerance, couple this to a carrier protein and an adjuvant, and thus producing a vaccine that will not only induce antibodies to this particular vaccinated peptide, which is modified from the epitope of the target protein, but also by cross-reactivity to the target protein, in our case, synuclein. And we showed in this study that this does happen in a small number of patients exposed over longer term to multiple priming initially and then booster injections, showing that A, there is, as expected, antibody induction to the immunization peptide, but also to the target protein at lower titers, and that this immunogenic response is boostable very rapidly after, in this case, 1 year and further on. This went on for almost 3 years. So the proof of principle is there. It was safe. These patients tolerated the vaccination well. It did induce the antibodies. The unanswered question is, will alpha-synuclein antibodies be helpful for patients? Now, coming back to this list of possible targets, is it reasonable to go for one like synuclein proteostasis in different ways? And we had a wonderful lecture in this presidential perspective series by one of my fellow MDS presidents and a good friend, Professor Tony Lang, who elegantly pointed out the many caveats and the many reasons to believe that we may not even succeed with a single drug, that we may need cocktails combining different drugs. And one of the arguments that this might well be the case is that patients with Parkinson's disease are heterogeneous, even to the point that some authorities would today rather speak of different Parkinson diseases than just of subtypes of one single disease. We've had attempts clinically to distinguish between clinically defined or by cluster analysis defined subtypes, and I summarized some of these common classifications of young onset or tremor dominant or postural instability gait disorder dominant, or clinical presentation or cluster analytic classifications. The problem with these is that they largely lack biological underpinning. There is a suspicion that they might reflect differences in pathology, molecular and maybe even gross pathology, although this has not been shown so far. But what we know at this point in time. There are biomarker-defined subtypes of the disease. We have the examples of monogenic Parkinson's disease. We have different clinical profiles in Parkinson's disease, patients carrying GBA mutations, for example, and there are many more thinkable and evolving genetic and non-genetic biomarker signatures. And I think this is what we will need in future to better focus our therapies that we are trying to find in the field of disease modification to certain subtypes, molecular subtypes of disease. And the other challenge here is the time point of when to intervene. This is a generic scheme applied to Parkinson's, but it's true for many diseases that before they become clinically manifest and produce symptoms, and even when they produce symptoms, they're not always immediately diagnosed and treated, that they, even before that, have a preclinical phase where there is the biology or pathobiology of the disease ongoing. And there might be in there, between the biological onset of the disease and the symptomatic onset of the disease, there might be a point in time very early on that this disease could become detectable through screening. And of course, it would make a lot of sense to detect it not only, but then to treat it if we have the treatments. And I just want to show you how the MDS has contributed to this effort by defining criteria for prodromal BD that are data-based, data-driven, approach-based, and we have been able to test them very early on after their publication in a population-based score, just to see how would they perform as a screening tool in the population. We had access to a smallish population by standards from other fields of medicine, but still they were truly elderly population-based patients, and they were being regularly followed in 5-year intervals. So we were able to calculate their prodromal scores for Parkinson's based on the MDS algorithm at this time point, and then which was 2005, and then follow them up to 3 years, 5 years, and 10 years. And what we saw was, using the algorithm by the MDS, we had certain probabilities in the total cohort at baseline depicted here, so the median was down here, and that those who developed Parkinson's within 3 years, looking back at their baseline scores 3 years earlier, were up here with the MDS score. Out of these 6, 4 were above the 80% threshold of that score, which is equivalent to probable prodromal. And incident cases became more after 5 years and even more after 10 years. And the overall probability score, the level of post-test probability, went down a little over years, which is easy to understand if you think about how some of these markers, or many of the markers in this risk score, are time dependent and become apparent closer to disease. So really, what the main message of this exercise was, it's possible using simple clinical criteria in the population to reach a certain sensitivity of prodromal Parkinson's within 5 years, which was above 50%, and a positive predictive value of 60%. And you can go up with this at the expense of sensitivity. If you follow patients for 10 years, you get higher positive predictive values and very high specificity using only clinical criteria. Now imagine if you apply algorithms in future that will include imaging information, genetic information, which are all partially part of the MDS criteria, but will also use by the molecular markers from biofluids and tissues. And that should enable us to disentangle the field, where we would be able to recognize preclinical and prodromal. We would also have a spin-off of being better positioned to identify subtypes and differentiate PD mimics. So Parkinson's disease will turn into a biomarker-aided diagnostic exercise in future, and hopefully open the door to earlier and more targeted interventions to achieve disease modification. And I would like to close with James Parkinson, who got 2 aspects completely right. From the current perspective, he was wrong at his time when he suggested that there was sufficient reason to hope that some remedy might before long be discovered by which at least the progress of the disease might be stopped. That was wrong at his time. There was no really sufficient reason for that at his time. But I think there is sufficient reason for this now, to have this hope. And I think he was completely right with this statement: the earlier, the better. What he didn't know was the nature of the disease. And we have progressed in understanding the nature of the disease, but we have a long way to go to understand the different facets of disease, and if we're dealing with one disease or different molecular types of Parkinson's disease. With this, I'd like to close, and thank you for listening and watching.